Well, thank you, Jürgen, and thank you for inviting me, and thank you all for coming out to listen to me. I really like talking about this Canadian project and what's going on, and I hope to learn a little bit more about what's happening in Finland at the same time. So that's all very useful. Jürgen said that my work is focused on health, and it is, but you have to understand that in the Canadian context, when people talk about health, they talk about it in a very broad framework. So we're really talking about health and well-being, quality of life. That's what we're talking about. And I think it's easy sometimes when we talk about basic income to talk about it in abstract terms and to assume that we're talking about some kind of a program that you can lift and drop into different kinds of cultures and different societies, and that somehow it's going to show up in the same way or have similar kinds of effects. And one of the things that I think this project does is to demonstrate how dependent the way that basic income appears is on the political orientation and the kind of institutional framework of the society that it's being dropped into. So one of the things that might surprise you about Canada is the leading role that the health sector has played in advocating for a basic income. I know in Finland there's very much a focus on basic income as a way of getting people attached to the labor market. I know in the US people keep talking about robots. Technological change is going to require basic income. But in Canada, the focus is very much coming from the health sector. And the idea is that, you know, it will be a healthier society. Population health will improve. People will be healthier and happier with the basic income. And when you ask public health advocates why they think basic income is a good thing, they generally focus on 3 or 4 things. One of them is precarious employment, and I'm sure you've heard about that ad infinitum, so I'm not going to spend a lot of time talking about it. The second is precarious employment leads to poor health outcomes simply because of the stress of living in an economy where you have no certainty about your future employment prospects. The second, and the most important from the public health perspective, is poverty. We know that poverty is associated with poor health and poor quality of life in all kinds of ways that I'll talk about. And the third is a little bit interesting because this is where the public health folks part ways from the labor economists. Labor economists are very keen that people should be attached to the labor force. They should be working. A lot of public health people think that one of the problems we have is that people work too much. And they think that one of the benefits of basic income is that it allows people to opt out of the labor force for either short periods of time to do things that are personally beneficial and beneficial for the economy and for society, but that don't necessarily attract a paycheck. So they'll talk about people providing care to family members, for example, or to involve themselves in volunteer or community activities. This is my only slide about precarious employment. This handsome-looking guy over here is the Canadian Minister of Finance. And he was musing that young Canadians are just going to have to get used to precarious employment. The economy's changed, and going forward, you know, that's just the way things are going to be. This second slide happened about 2 days later at a national labor congress where the youth delegates turned their backs on the Prime Minister and suggested that it might be the finance minister who should experience a bout of unemployment. So there's a good deal of angst about the nature of the economy. Right now, precarious employment probably accounts for about 22% of the Canadian economy. But of the new jobs being created, more than half of them would fall into the category of temporary, low-waged, usually non-unionized activities. So let me move on to poverty. What do we know about the relationship between health outcomes and low income? Well, we know all kinds of things. Most of it is based on simple correlations. We know that people living in poverty have lower life expectancies. In some of the most challenged cities in Canada, if we look at people living in the lowest income decile and compare them with people living in the highest income decile, so the poorest 10%, the richest 10%, the difference in life expectancy at birth for men can be close to 14 years. These are in cities like Hamilton, like Winnipeg. And a lot of that difference in life expectancy comes about because of violence, because of self-harm, as well as other things. We know that chronic conditions fall more heavily on low-income people. If we look at diabetes, for example, you're more likely to end up with adult onset or type 2 diabetes if you're low income. But it's not just the prevalence of diabetes. If you become diabetic, the secondary effects, the complications of diabetes, hit low-income people much more heavily. So if you're a diabetic and you're low income, you're much more likely to suffer things like limb amputations, leg amputations, or blindness associated with diabetes. And I can go through all of these, but I think these are things that are straightforward. Lower your income, the poorer your health outcome, and there's all kinds of evidence to suggest that. This is just a diagram that the public health folks use to summarize this sort of argument. And the argument is really that socioeconomic factors and the physical environment that you live in, the nature of your neighborhood, the job you work at, the housing you live in, and your income probably accounts for 50% of your well-being. Healthcare, on the other hand, hospitals, physicians, and so on, that can only account for about 20% of how healthy you are or how sick you are. Health behaviors, the things that we all like to focus on, you know, tobacco use and diet, alcohol use, and so on. Again, that accounts for only about 30%. So it's these upstream determinants of health, if we can call it that, the physical, the nature of the built environment, the nature of the city you live in, the amount of green space you have access to, and the socioeconomic factors, your employment, your education, your income, the nature of your community support. All of those things account for about 50% of how well you rate your health. Before I talk specifically about experiments, either current ones or past ones, I just want to say a little bit about the nature of the social system in Canada. About 12% of Canadians are living in poverty based on one of our many measures. So this diagram, the blue stuff, represents the 87.3% of Canadians who do not live in poverty. The red represents seniors living in poverty. So 1.7% of Canadians are seniors living in poverty. It's the other two wedges that are interesting. The yellow wedge are people living in poverty who are on income assistance, so 5.1%. But the biggest bulk of people living in Canada in poverty are people who actually work for a living. So 6% of the Canadian population is living below the poverty line and working at least one job, in many cases more than one. This is that same, if I take that wedge there and blow it up to a full pie, this is the same thing. So 46.9% of poor people in Canada are working age people and children who do not collect social assistance. Seniors account for a very small part of the wedge, and even income assistance recipients account for only about 40% of people living in poverty. So poverty is really a problem in Canada until now for children and for people of working age, and I would say specifically for people of working age, and specifically a problem for the working poor, because as you'll see in a minute, one of the great gaps in the Canadian system is that we have virtually no subsidies for low-waged labor. Just going forward, I want to, the state of play right now in Canada, we've had this conversation about this basic income experiment. And just a week ago, a discussion paper was released by this guy, Hugh Siegel, who published wrote 100 pages about what a basic income ought to look like and how the experiment should run. And the nature of the conversation has changed a little bit in recent weeks in Canada. There have been a lot of people opposed to the notion of basic income coming from all different sectors and all different points of view. But since slightly before the publication of this working paper, there's been a recognition that basic income is coming. We're going to have an experiment. We may very well end up with a policy. So now the nature of the debate has shifted a little bit from should we have basic income or should we not have basic income to, well, we're going to have basic income. What should it look like? How do we make sure we get one we can live with? So, emerging consensus, what can I say? There's an emerging consensus in Canada that basic income is one policy among many. one arrow in a quiver. We're not going to replace the entire welfare state with the basic income, which was a fear of some of the progressive organizations in Canada. We require a lot of different policies to address different issues. The third one is that basic income should be organized as a negative income tax. And I'm going to talk about an older experiment in a minute. But in Canada, the only way that we've conceived of basic income is as a negative income tax. And a negative income tax is where the payout is targeted towards low-income people. So if you have no money from any other source, you received a certain fixed amount of money. As your income from other sources, and in particular from working, increases, your benefit declines. So it is income contingent. We're not considering in any way a demogrant. The latest I heard is that Finland is considering a demogrant, so we can leave it to you to experiment with that and find out what happens. And the final thing that I think there's a great deal of agreement on is that nobody who depends on existing support programs should be made worse off under a basic income. Whether that's possible is something that we'll talk about. And I just want to mention a few of the existing programs that we currently have in place and how basic income fits into it. Employment insurance is for short-term unemployment, and it's an insurance program funded through contributions from employers and employees. CPP, Canada Pension Plan, is a wage-based contributory scheme for seniors for retirement. But the other two are more interesting because these are actually forms of negative income tax that we already have in Canada. The Canada Child Benefit is in effect a basic income for people with dependent children. So low-income people receive $6,500 a year for children under 6, $5,500 a year for children between 6 and 17. As their income increases, the benefit declines. But this is really a game changer for people with young children, and it is a form of basic income. The second one's been in place for much longer, and that's a form of basic income for seniors. OAS is a basic pension payable to everybody, and GIS, the Guaranteed Income Supplement, is again an income contingent negative income tax that supports low-income seniors. So we actually, at the two ends of the age spectrum, we've already got negative income taxes, kids and old people. What we don't have is any kind of a scheme for people of working age. So that's what the focus is on, that sort of mess in the middle. The programs we have that are less successful are basic income assistance and disability support programs. These are for people of working age. And the criticisms of these programs are the criticisms that exist around the world, so I don't need to go through them. And then there are some programs that we really don't have at all. We really have no support or subsidies for the working poor, and nothing substantial. We really have no housing benefit in Canada. So one possibility then is to use a basic income to replace income assistance and disability insurance and to keep everything else in place. And that's pretty much what the decision's been. So is there any evidence at all, if I can get back to health, that a targeted basic income will improve health outcomes? Well, because we've already got these basic income programs in place, we do know a little bit about what the effects are on people's health. We know that when we introduced the child benefit, children ended up doing better in school, but it also improved children's mental and physical health outcomes, and it improved the mental health outcomes of mothers in particular. So some evidence that it improves health. There are other kinds of small programs in place. This was a particular program that paid pregnant women $80 a month, a minuscule amount of money, but it was unconditional. People could spend the money any way they wanted to, and it had an impact in terms of low birth weights and in terms of fewer preterm births. And the conclusion drawn by the authors is that you don't need to place conditions on income supplements in order to improve health. Unconditional cash transfers work. This is one I particularly like. If we look at food security, We've got a number of ways of measuring food security, but if we look at food security and imagine it as a measure of a real material deprivation, food insecure households are among the poorest households we deal with. And we look at who's suffering from a food insecurity in Canada. Again, the biggest bulk of food insecure households are people who have jobs, the working poor. And there are a number of different mechanisms that have been posited for how food insecurity affects health. It certainly affects children in terms of learning, in terms of basic health outcomes. Adults, physical and mental health, complications of chronic conditions, and so forth. But this is what I really want to show you. This is the probability of suffering from food insecurity by age, and these are among single adults. And you can see that the probability of moderate and severe food insecurity is quite high, up to about here. And then we get this massive decline almost overnight. So it goes from just over 26% to about 11% almost overnight. So what happens? What happens at age 65? You know, how does the world change? Well, there's only one thing that changes there, and that's that these people have a birthday. And when they go from being 64 years old to being 65 years old, they go from being dependent on a really inadequate income assistance program that pays very low rates of support to being eligible for a much more generous basic income as a 65-year-old. So again, I think that's a very telling notion of how basic income can affect health. Anyway, that's all by way of preamble. Now I want to talk about what I've spent a lot of time doing in the last little while. In the 1970s, there was a real reconsideration right across North America in terms of how we should deliver social assistance. And the idea of a negative income tax was experimented with. There were 5 negative income tax experiments in North America, 4 in the US, and 1 in Canada. And the idea when the Canadian case was introduced in 1974 was that this was going to be the best of the 5 experiments, right? They were going to do, this was just going to be the best outcome. Well, they introduced it. It started in 1974. It ended in 1979, and it ended in almost complete disarray. Politically, and this is something to keep in mind, I think, around the world, halfway through this experiment, governments started to change. This was a government-sponsored experiment. In Canada, it was 25% of the costs were paid for by the federal government, and 75% of the costs were paid for by the federal government and 25% by the provincial government. The provincial government changed in 1976, and the new government was much less interested in the whole idea of basic income. So it lost political support. Whoops, I'm not sure what I've done there. A lot of things were happening at the same time. As I said, there were 4 similar experiments that were conducted in the US as part of President Johnson's war on poverty. But there were a lot of things happening in Canada at the same time. This was a time when all of our social programs were being made more generous than they were previously. So this was when universal health insurance was introduced in Canada. It came in 1971, and you'll see why that's important in a minute. This was when the Canada Pension Plan was introduced. Disability pensions, unemployment insurance were made more generous. MINCOME, which was the name of the experiment for minimum income, was set up in an interesting kind of a way. There was a standard experiment, a randomized control trial that was run in Winnipeg on a dispersed sample. And there was a second site in a town called Duphin, Manitoba, which was a saturation site. And the cool thing about a saturation site is that everybody in town is eligible to participate. So in Winnipeg, we're talking about, maybe 1,000 families were invited to participate out of a population of 450,000 people. But in Duphin, this was a town of about 10,000 people. Everybody was eligible to participate. Now, they didn't all get the money. They only got the money if their income fell below the agreed upon threshold because it was a negative income tax. But they were all eligible to participate in the experiment. And what makes this important is that everybody received the promise. So if you imagine a basic income as a form of insurance, a form of income insurance, everybody was a participant. Because even if your income was too high to collect, you knew that if your income fell for whatever reason, this program existed and you'd be eligible for it. Just a map so you know what we're dealing with. It's right in the middle, a flyover territory in Canada. At the time, in 1974, there were about 750,000 people in this whole province. One urban site, Winnipeg, which had about 60% of the population, so 450,000. Duphin's about a 4-hour drive away, and it had about 10,000 people in it. And the purpose of this experiment was to find out what effect a basic income would have on the labor market. And it's interesting to think about it in terms of the current debates, because I know that in Finland, the idea is that the idea of introducing a basic income is to encourage people to join the labor market, to participate. The fear with this was that if you give people a reasonable amount of money, they're going to stop working. They're going to reduce the number of hours they worked. So the project was set up to find out whether people, in fact, stopped working or worked fewer hours. It was set up in such a way that it was voluntary, so it had to be more generous than the existing program to encourage people to participate. And the way it was set up was that if you qualified, if you had no money, you got a benefit level that was just slightly higher than the existing welfare amount. And for every dollar that you earned on the labor market, your benefit would fall by half, by 50 cents. So your benefit falls, but it falls less than proportionately. That was in Duphin. In Winnipeg, they tested a variety of different designs. So what did they find out? Well, there was some labor market work that was done in the early 1980s. And the first thing they found out was that if you're a grown-up person with a real job, you don't quit that real job that pays a decent wage in order to live on benefits. There was virtually no effect on full-time workers who were adults. But there were two groups of people who did reduce the number of hours they worked pretty significantly. And they reduced them in interesting ways. Married women. Now remember, we're talking about the 1970s. So this is a period of time when women are just moving into the workforce in large numbers. So many of these people had jobs rather than careers. Many were working part-time. And it turned out that they used the income money. They used the benefit to buy themselves longer maternity leaves. Okay? Again, Canadian context. In the 1970s, the entitlement to maternity leave was 4 weeks. So you have a baby, you get to stay home for 4 weeks before you have to go back to work. Turned out that a lot of people thought that was pretty short, and so they used the money to buy themselves longer parental leaves. And the second group that had a big reaction, and here language turns out to be really, really important, are young unattached males. Young unattached males reduced the number of hours they worked really dramatically. And I've used slightly different language because we're really talking about teenagers. We're talking about adolescent boys who reduced the number of hours they worked. And that's really where my project started. When this was set up, when MINCOME was set up in the 1970s, they wanted to collect all kinds of information on health and social effects. But it turns out they didn't do it. Here, we're dealing with sort of the pragmatics of experimentation. The project started in 1974. No one knew exactly what it would cost. But the researchers negotiated a budget of $17 million for the entire project. Out of that $17 million, they had to pay the families, and that was a legal requirement. From the money left over, they had to collect the data. And if there was any money left over, they would do research. They would do analysis. Well, 1970s were a difficult time. If you've done some economic history, you know that around the world, the 1970s, we faced a couple of oil price increases. Inflation went very high. In Canada, it went to about 12%. Interest rates went to about 19, 20, 22%. People were losing their houses because of the economic conditions of the period. So inflation was extremely high. When inflation hit, the payouts to the families went up because they were adjusted for the cost of living, but the $17 million budget didn't change, right? At the same time, they'd hired lots of interviewers to go and gather information from families, and those interviewers started to demand higher wages because, you know, if you weren't prepared to pay them more with inflation, they weren't prepared to work for you. So it cost more to collect data. And what that meant was that the costs were going up, but the budget wasn't going up. And so they started to run out of money. And the experiment was also run by economists. And so the economists decided that the way they were going to cope was to cut all of the peripheral research projects, all of the less important research projects. And it turned out that they thought all of the less important research projects were the ones run by the sociologists. And so they cut all of the health and social analysis. So they collected data. A lot of data was collected, but there was no analysis done on the social issues. So a few years ago, I was wondering if we could actually find out what happened to these families. Were they healthier? Were they happier? So I went looking for the data, and I eventually found it. It changed hands several times after the experiment ended. The experiment ended with no final report. The data was essentially in an office building, and then it changed hands several times. I finally tracked it down, and I tracked it down in 1,800 of those little boxes. So 1,800 cubic feet of data. We're talking about paper. There's no database, right? And so that was kind of fun, but it was a bit overwhelming. And so I was wondering if there was some way to figure out what the health and social effects might be. And we faced a couple of constraints. I wanted to be able to talk about causation. I didn't just want to look at correlation. I wanted to be able to talk about causation. And I was constrained by the way the experiment was done. So I couldn't go back and redo it and do it in a way that I would like it to have done. So the first thing I did was to get some high school enrollment figures. I remembered those teenage boys who reduced the number of hours they worked, and I had a fair idea of where I'd find them. And so I called a friend of mine in the Department of Education, and I got data for school enrollment in all the high schools in Manitoba. And then I put them into 3 categories. The first, and that's the cream-colored bar you'll see there, the purple bar, the dark purple bar you'll see there, is Winnipeg. It's the largest portion of the population. The light purple bar represents high schools in Duphin, and the cream-colored one is the rest of Manitoba. And what we're really talking about here is high school completion rates. And remember, the money started to flow really sort of midway through 1974, okay? So if you look up to here, these first 4 sets of bars, you see exactly what you'd expect to see. Kids in the urban center are more likely to finish high school than kids in the countryside. No surprises there. Virtually no difference between Duphin and the rest of rural Manitoba. This light purple and this cream-colored bar, they're pretty much the same. But look what happens over here. We get to 1975, the money's flowing, and the Duphin bar goes way up. It goes up to almost 100%. 1976, it goes above 100%. 1976 in Duphin, kids who'd already left school without their complete high school were coming back to school to finish high school. 1977, the money's running and kids are finishing high school. 1978, kids are finishing high school in Duphin. Money stops flowing, and we go right back to where we started from. So we've got this little bubble, and I've effectively found those teenage boys who quit their jobs. Instead of leaving school at the age of 16, when they're entitled to, and taking a job, and there were jobs, they stayed in high school a little bit longer. So is this a bad outcome? The kinds of jobs that they would have gotten at 16, they would have gotten jobs in agriculture or in manufacturing, and those industries have been totally destroyed since the 1970s. They've really declined. So if you use your imagination a little bit and think about the long-term impact of those kids who left as opposed to the kids who stayed, you can imagine that their lives are bound to be very different. The kids who finished high school, on the other hand, had the option of going on to college, to university, to getting different kinds of jobs. Okay, that was the first thing I did. The second thing I did was to look for registry data. Now, I realize I'm in a part of the world where you guys have registry data, so this isn't nearly as big a deal here as it is in North America. This is very unusual in North America. This database grew out of universal health insurance. So if you lived in the province of Manitoba at any time between 1970 and the present, I've got you in that health registry. And you're identified by a 9-digit personal number that essentially traces you from birth to death. and a 6-digit family number that allows me to track family formation and dissolution. So I can track marriages and divorces. I know where you lived. I know the 6-digit postal code where you live. So this is a very fine geographic region, which means I can tie it into the census. And I can find out a lot of information about you from where you lived. And I've got it tied into probably 120 different social and health databases. At the time, this was not nearly as sophisticated as this. At the time, what I had was the hospital database, health services here somewhere, provider, which is family doctors. I had vital statistics. And that's pretty much what I had at the time. So what I was able to do was to go into this database and to find people who participated in the experiment and to create a control group. And so first of all, how did I create the control group? Well, I wanted to find people who were like my Duphin residents as much as possible. So out of that database, I removed the people who were very different. So I removed people living in the urban center because cities are different than the countryside. I removed the people living in the north because the north is sort of culturally and socially different. And I removed people living on Indian reserves, First Nation reserves. And the reason I removed the reserves is because if you live on a reserve in Canada, your health care is provided by the federal government as opposed to the provincial government, so you don't show up in the database in the same way. And what I had left, once I'd done that, what I had left is people living in a whole lot of towns, pretty much like Duphin. And so I had my Duphin residents, I had people living in places a lot like Duphin. And what I tried to do was to find 4 controls for every subject that were matched on a number of different categories. In the event, I ended up with 3 really good matches for every Duphin resident. So if you're a 21-year-old woman living in Duphin, I found 3 other 21-year-old women living in places a lot like Duphin, in families of similar size, and so on. And then I went and I looked at hospitalization rates. And the blue line represents Duphin, the red line represents the controls. And what you can see is that before MINCOM came along, if you lived in Duphin, you were more likely to be hospitalized. I couldn't measure health. All I can measure is sickness, in a sense, assuming that if you go to the hospital, you're sick. So before 1974, you're more likely to be hospitalized if you live in Duphin than if you're a member of a control group. When MINCOM came along, those 2 lines start to move together. By the end of the experiment, there's no statistically significant difference between Duphin and the controls. So what that means is an 8.5% reduction in hospitalizations over that period. When I looked more specifically to find out why people were being hospitalized less often, 2 codes showed up as really significant. Now, the first, accident and injury hospitalizations, is a huge category that covers all kinds of things, and I couldn't look at any finer detail. But a large portion of accident and injury hospitalizations are things like car accidents, many of which are alcohol-fueled, farming accidents, industrial accidents, and so on. The second category, from my perspective, is a little more interesting, and that is many fewer hospitalizations where the primary cause of hospitalization had to do with mental health. So we get a reduction in mental health hospitalizations, which perversely, I say, means we had an improvement in mental health. I looked at visits to family doctors, and I found the same pattern. There's a decline in visits to family doctors for Duphin residents relative to the controls. And when I looked for reasons why, the only thing that showed up as statistically significant is fewer people showing up with mental health issues, showing up with depression, showing up with anxiety, and so on. I looked for a number of other things because it would have been nice to find them. I looked for birth outcomes. People who work on poverty always like to find differences in birth outcomes because low birth weights, babies that are small for gestational age, tend to be related to poor health and poor educational outcomes throughout childhood. So if you can show an improvement in birth outcomes, you've really done something. It turns out I couldn't find that. It didn't show up significantly, so that was a bit disappointing. I think largely because even though I had 10,000 people living in Duphin, it turns out that 10,000 people don't actually produce that many babies in a 4-year period. So I'm dealing with the fairly small numbers here. And even among babies that are coming from the most challenged families, most babies are born healthy. So sick babies are a fairly rare event. I looked at perinatal death, for example, and I didn't find any during the entire period. No babies died, which is sort of unbelievable. I also looked at 2 other things because they were political issues during the period, especially in the US. One of the criticisms of a basic income in the US during the period was, well, all those boys are going to stop working and all those girls are just going to stay home and have babies in order to increase their entitlement. So I looked at birth rates in order to see if, in fact, people chose to have babies in order to increase their benefits. And I also looked at divorce rates because, oddly enough, there was the fear that there was the suggestion in initial research that in one of the US experiments, divorce rates were influenced by basic income. That if you give people basic income, divorce rates increase. Now, I have no doubt that divorce rates were increasing during the 1970s. And I think we can all imagine marriages that probably ought to end in divorce and sometimes don't because at least one of the participants fears poverty. But that's not really what they were talking about. What they were really saying was, if you give these women support, some of them are going to decide they can do without their husbands. And this was not something that American senators were very keen on encouraging. So these became really politically touchy issues in the US. And so I looked to find out if there was an effect on birth rates or divorce rates in Duphin. And it turns out there weren't. So what can I say overall? I think the Duphin experiment lets us say that kids might have been most affected by the basic income. They stayed in high school longer. If anything at all happened to birth rates, they tended to have fewer babies later in life. And both of those are associated with better outcomes. This is one of the participants. She died just a year ago, Amy Richardson. This is her family during the 1970s. And her story is kind of interesting. She had a disabled husband who actually died during the period of the experiment. So she went from being a young mother with 6 kids to being a young widow with 6 kids. And she cut people's hair in her house. She ran the Duphin beauty parlor out of her home. And this was her opinion many years later. The point of MINCOME was to bring your income up to where it should be. So it didn't create a luxurious life, but it was enough to add some cream to the coffee. Everyone was the same, so there was no shame. And when we talked to a lot of participants in the Duphin experiment, everybody mentioned the lack of stigma associated with the basic income. So I've only got 2 slides left. And I'm going to ask 2 big questions. The first is, why does Canada need another experiment? If we look at Duphin, if we look at the MINCOME experiment, we know that the labor market effects were small. People simply don't quit their jobs in large numbers if you offer them a basic income. We know from the MINCOME experiment and from lots of other data that health and quality of life improves when you offer people a basic income. We know that educational outcomes go up. We've also already introduced basic incomes for 2 portions of the population, the very young and the very old. The only thing we haven't done is to deal in a reasonable way with the mess in the middle, working age adults. Why do we need an experiment? And I say that with a bit of frustration because I'm a little worried about the idea of an experiment. I think there are things we can learn from a new experiment. I think, for example, no matter how many times you produce data, there are still people who worry that if you give working age adults a reasonable basic income, they're going to stop working. And in Canada, that's an almost impossible fear to get past. The second thing is that the labor market now is a whole lot different than it was in the 1970s. So there are real questions about whether you can generalize those results from the 1970s till today. Now, I would say that in a sense, a small town labor market in the 1970s has become like the entire labor market today. But again, there are questions of generalizability. And there's some interesting experiments we can do to find out more about how a basic income works. But I'm really worried about the idea of a basic income. We're talking about, in Canada, in Ontario, we're talking about a basic income that would take 3 or 4 years to run. The public doesn't have an attention span that's going to last 3 or 4 years. It's going to be very hard to keep the level of enthusiasm that exists right now, I think, alive for the next 3 or 4 years. Secondly, I think that there are some real limitations to what you can do in an experiment. We can look at the supply side of the labor market. We have a much harder time experimenting with the demand side of the labor market. You know, we're observing over a period of 3 years, we're observing short-term fluctuations. We're not necessarily capturing secular changes. And most importantly, I think the biggest lesson we can learn from Duphin is that if you're going to run a large-scale field experiment, you need government money to do it. And governments change. And, you know, that killed the Duphin experiment. And I worry a lot, because the place where the greatest enthusiasm for running an experiment is Ontario. The current government has a year left in its mandate. Not at all clear they'll be re-elected. So anyway, my position on Duphin. Thank you very much for your attention.